A very good evening and warm welcome to all the participants for this 54th Leadership Conversation. Ladies and gentlemen, we are having this conversation with a great leader who is with us here in Hyderabad, Dr. Evita Fernandez. There are many memories. There are many very good memories for most of you as well who have joined about Fernandez Hospital, about Dr. Evita, and about the birthing processes. I think many of my friends, many of those who have not joined or could not join today have expressed their experience, their memories, and they shared a lot of comments on Facebook and Insta about this particular conversation. And everyone probably seems to be having some connection with Fernandez Hospital and Dr. Evita. So all of you, please join me in welcoming Dr. Evita Fernandez to this conversation. Ma'am, welcome to you once again.
Thank you, Mr. Sudhakar. Thank you.
On behalf of the entire ICFAI group and on behalf of everyone present here, I would like to thank you for sparing this time with us in spite of your busy schedule. I personally understand how much busy you are on a daily basis. And I have been in kind of follow-up with you for the last 6 months to seek your time. And today I'm very lucky that you're going to talk to us.
You're embarrassing me. You're embarrassing me. I'm not supposed to get.
No. But I totally understand why it takes so much time, because you are totally busy and there are lots of programs. You speak in various conferences, you conduct several interventions, and therefore you're extremely busy. So thank you, ma'am, once again. I will now begin with a small introduction, and after that, I'll hand it over back to you for your opening remarks and presentation. This is the 54th conversation. As I mentioned, every Friday, we are having this at 7:30 p.m. Today, we have with Dr. Evita Fernandez. As I mentioned, she's going to talk about care versus cure, implications for maternal and child healthcare management. The first half an hour is introduction as well as presentation by the guest, Dr. Evita Fernandez. And the next half an hour is the Q&A session moderated by Professor Prasad and myself. Always cheerful, ma'am. Yes, this is the briefest introduction that I can share with the audience today. Dr. Evita Fernandez is a renowned obstetrician and the chairperson of Fernandez Foundation, Hyderabad. In a career spanning 3 decades, Dr. Evita has been at the forefront of maternal and child care in India. She is a fellow of the Royal College of Obstetricians and Gynecologists, London. Apart from the several other achievements, Dr. Evita is a champion of natural birthing and midwifery in India. She has spearheaded the country's first professional midwifery education and training program, abbreviated as PMET. Her professional midwifery services campaign, which is again abbreviated beautifully as PROMISE, is committed to creating a national cadre of professional midwives who are vital to the care of low-risk pregnant women. Dr. Evita strongly believes in the need to empower women, and I have seen this personally, need to empower women to make choices, especially with regard to issues surrounding birth. My 2 daughters were born in Fernandez Hospital in Hyderabad, and so I have gone through, and I will share those wonderful moments probably when we have time towards the end, and others also probably will chip in to share their own experiences. I will stop the screen sharing right now, and I request ma'am to speak now, and it's all yours, ma'am. Once again, thank you and welcome to start the presentation.
Thank you, Mr. Sudhakar. You've been very generous with your introduction, but thank you very much. I'll just share the screen and we'll begin. Thank you very much for giving me this privilege, Mr. Sudhakar. And you chose the topic, care versus cure. It's a very interesting perspective that you asked me to speak upon. I'd like to start by saying that you can't actually have one against the other. They're like 2 hands clapping together. You need both. You can't heal without caring. So cure and care go hand in hand. Those of us who are involved in the healthcare profession, I strongly believe we come into this profession because we feel a calling that is based on compassion, a calling that makes you want to serve, that wants you to take away suffering and provide healing. Now, in response to your focus and your request on focusing on maternal health, and I'm so grateful for that, because that's all I've been involved in as a professional. And we know that this is there's wide variation across the country. I'm not sure how many of you know that we have an annual birth rate of about 26 million a year. And with all the disparities that exist, women are not offered the kind of care that they have a right to accept. Healthcare today is in deep peril. There's tremendous distrust of the medical fraternity, and I do believe that some of us have actually called this upon ourselves. There's a lot of technology. There's focus on cure, on disease. There's rising costs, and apart from the corruption that exists, we also know it's the fastest growing industry. So with this background of absolute lack of trust, violence against medical fraternity, information being so easily available at everybody's fingertips, and rightly so. And then you've also got the pros and cons of digital social media. So with this background, how do we offer care that will cure? Coming from the view or from the professional part of healthcare that I have been very privileged to be involved, we are drawn into very, very vulnerable situations. Birth and death are significant moments in people's lives. And to be a part of this significant moment is a sacred privilege. And I've always looked upon that as a privilege. And privileges are lined with responsibilities. Today, I'm going to spend the rest of this time talking about why birth and the way women give birth is so vital in birthing the next humanity or the new humanity. Why? Because the way we are born and the way we give birth has long-term implications on a woman and the bonding that exists with her baby. If a woman gives birth in an environment where all the people in that room, her midwife, her nurse, her doctor, are caring, supportive, and there is no fear in her, then she emerges as a very confident mother, stepping into motherhood with tremendous confidence and security emotionally. But if she's in an environment where there's abuse, disrespect, lack of privacy, dignity, her choices are not respected, she is traumatized for life. And that's why there's something called human rights in childbirth. And India hosted this conference in 2017. And a lot of us have forgotten that birthing women have this fundamental human right to choose where they want to birth, who they want in the room, and the mode of birth. And there's a very thin line between respecting a woman and giving her that choice, telling her all the pros and cons, and she still has the right to decline treatment. So what matters to women during childbirth? This is an amazing systematic review that came out in 2018. Women want a positive experience. It doesn't matter if they have a normal birth or if they have a cesarean. What they want to feel at the end of it is, I was treated with respect and dignity. Of course, they want a healthy baby, but they want to be in a safe environment, psychologically safe environment. And I draw your attention to the last, which fits in with our title, emotional support from competent and kind clinical staff. So cure and care go together. Now, birth experiences, and I feel very, very strongly about this because this is evidence that is emerging more and more in the last 10 to 15 years. We know that birth is a significant event. And this transition of this young girl becoming a mother, because at birth, it's not just the birth of a baby, it's also the birth of a mother, particularly if it's the first time she's giving birth. Her entire self-esteem, emotional, mental health depends on how that experience affected her. And what I found was even more interesting when I started working with midwives and began midwifery training 11 years ago, is that birth memories last a lifetime. Women remember every bit of conversation that happened in that birthing room, and it stays with them for life. And this has certainly changed the way we practice in Fernandez today. Now, many women don't come into hospital facilities if they've had a traumatic birth the first time. And this can lead to mental health issues, postpartum depression, and may even prevent them from having another baby, or they don't seek care. So it's extremely important how women give birth and what kind of an experience they have. So that's why 4 international organizations came together and said, disrespect and abuse needs to stop. Are patients truly at the center of care? And I think this is the most important question we who are privileged to run our own establishments need to constantly ask ourselves. Are we placing the patient, in this case at Fernandez, we deal with pregnancy, that's 85% of our work. Do we put the mother and the baby at the center of all our decisions? Do we hear the woman's voice? And this is a hard question, and we always need to ask. Now look at this birthing room. Does this show that we care? Imagine women birthing in this environment. There's absolutely no respect for cleanliness, nothing. So it's not surprising when the White Ribbon Alliance in 2018 started a campaign, and they had just one profound question. What is it that women in India want? And they asked about 150,000 women across 24 districts. And the aim was to amplify these voices, and hopefully this would change the quality of care. It was called My Health, My Voice campaign. And there was a clear questionnaire women actually wrote down. And 2 out of every 10 women asked for dignity and respect. And just see what they asked for. 1 bed in hospitals with large volumes and not enough infrastructure. It's quite traumatic to see what women go through. They want a clean toilet, a clean labor room, respectful behavior by the doctor. So now at the end of the campaign, do we want to know what women want? You'll be surprised. Kindness, respect, information. Even the poorest woman has a right to know what you as a doctor are going to do for her. And why is it you advise whatever you are advising her? They want to know that whether you're going to have medications available, or do they have to run to the outside shop and buy everything when everything is supposed to be free? Can they have a birth companion? It's a woman's basic human right, not to birth alone, but to have a companion of her choice. And sadly, 70% of our mothers across our country birth alone among strangers. Can you imagine the fear that women experience? And we know today that women should be given the freedom to move, because when you have a woman in the upright position walking around during labor, gravity helps the descent of the baby down. It cuts short her time of labor and facilitates normal birth. But yet, we continue to train in very archaic practices which have no scientific basis, and we have women lying in bed for hours during labor, not encouraged to move around. These voices went global. So globally, the movement amplified to 114 countries and became a very strong voice in 2019. women said, we have to stop this disrespect and abuse. WHO said, every woman has the right to the highest attainable standard. And I draw your attention to dignified, respectful care during pregnancy and childbirth. So what do we mean by respectful labor and childbirth care? It has to begin with knowledge. We need to tell the woman how to handle labor and birth, because that's the most frightening part of her journey into motherhood. And we need to assure her, we need to give her options of how to handle pain, assure her of exercises, prepare her for labor and birth. And so we offered classes in different languages and at a very, very nominal cost, because knowledge should not be tagged with price. Emotional support from a companion of choice. And Cochrane is more or less the place any doctor goes to look for scientific evidence. And when Cochrane says, evidence says this, most of us take it as gospel truth. And just look at this. They said that women require emotional support. And we, healthcare professionals, have an ethical, legal obligation to provide safe and respectful care. All women should have support through labor. And this was way back in 2007. And this is the single, simple, most important intervention, scientific proof. And just see the amazing impact of just having a companion of her choice. Her risk of cesarean comes down. The need for pain relief, the need for intervention is decreased. And this is what the government of Telangana is doing. And we are so privileged to be involved in this. We've been training nurses to be midwives, and we'll talk a little bit about that. And this is in a district hospital of Telangana, a public hospital. A young woman has her husband with her during her labor and the birth of their first child. And I can't tell you the joy that this young woman experienced. Continuous support in labor has amazing advantages, and you can see that on the slide. And she can choose anybody she wants, but today you can have a midwife, a doula, a birth partner. Women who receive midwifery care. Now, this is hardcore evidence from way back 2016, are less likely to end in a cesarean. That's interventions, and more likely to be satisfied. And it says most women should be offered midwife-led care models. And yet, we obstetricians continue to be involved in the care of uncomplicated pregnancies. Now, if you take 100 pregnant women and put them in a room, 75% of them are healthy, uncomplicated pregnancies. The 25% who are complicated require obstetricians. 75% require midwives. And midwives are an amazing breed. The WHO says a midwife has to be duly recognized. She's completed a prescribed course of studies, registered and legally licensed. So not anybody can be a midwife. In India, you need to be a nurse and go through 18 months of training. And look at what she does. She promotes normal birth. She recognizes complications very quickly. She is able to call for help. And that's what we mean by collaborative care. The minute she knows that this mother has developed complications or anticipates complications, she calls for help. The doctors then come in, and together midwives and doctors work. And this is how we prevent maternal morbidity and death. So countries that have invested in midwifery as the backbone have very low maternal mortality ratios. Look at UK, look at Sweden. Their maternal losses are in single digits, while we are still struggling at 113 per 100,000 births. So midwifery-led care is high quality care, because she has to be knowledgeable, confident, highly skilled, and with all the other skills of communication and dignity, respect being offered to women. So these are all the advantages of midwifery-led care. And I just want to very quickly show you glimpses of what the Telangana government is doing in our public hospitals in the districts. This is a beautiful picture of the midwife and a woman. Earlier, the women used to stand while the doctor or the nurse would sit and take her history. That's changed. Now women have to sit, eye contact has to be established. And we are now teaching them certain exercises. Again, childbirth classes in a very busy public hospital is being conducted. And look at the joy on the faces of these women who are being taught how to handle pain. We're teaching them exercises of how to sway from side to side, because that helps them cope with pain. Look at the eagerness on the faces of these women in our public hospitals. And again, this is one of our hospitals where nurses are being trained for Telangana government, and the husband is now involved. And can you see that birthing ball? That's a gym ball. And if a woman is experiencing pain, and we don't have access to medication or epidural anesthesia like you have in a lot of our private hospitals, if you get a woman to sit on that gym ball and hold that rope that is hanging from the ceiling and get her to sway on it, you'll be amazed at how much relief she gets of pain. And if somebody can massage her back, and that is the young man, her husband, who's now learning to do that. So this is all part of respectful, compassionate care. And again, you've got midwives doing this, and one more husband is willing to learn how to support his wife in labor. So within 3 months, if you look at the slide, you'll find that 23% in December was the rate of normal births. And once the midwives began to work in the hospital, the C-section rate from 77 dropped to 67. Now that's enough proof to show you that where you have midwives offering care and providing this cure, you will find an amazing impact on outcomes. So in Fernandez, we decided to walk the talk, and we created a midwifery-led unit, which means out of the 10 delivery rooms on this floor, 5 are handled by obstetricians, 5 are handled by midwives. And where the midwives handle these women, these are healthy women, no complications, and there's no need for the obstetrician to be there. The obstetrician is called if the midwife needs her or she detects the need for an obstetrician to come in, or if the woman asks for a doctor. Now, I just want you to know that we had 656 women going through the midwifery-led care unit to have their babies. 90% had normal births. And I draw your attention to the cesarean section rate. It's less than 4%. So this further proves that when you categorize your mothers, take the majority who are uncomplicated, healthy mothers, put them in the hands of midwives trained to global standards, and support them with that. You stand in the periphery, step in when we are needed. The outcome is brilliant. So now let's move to compassionate care. Care and cure go hand in hand. Where there's compassion, patients heal faster. It saves time, and certainly it costs less. It's not so much technology that we need. Yes, while it plays its role, unless there's care for that person and looking at an individual holistically, cure is never complete. There's a very interesting article on the characteristics of compassionate care during childbirth. And I've just highlighted what they talk about, what they mean by compassionate care. When a midwife is taking care of a woman, but stays beyond her shift, because now she's established a level of trust and stays to help that woman birth, that's compassionate care. A woman never shouting, a woman receiving respectful care, the midwife not shouting, not goading her, not slapping her, but just supporting her and encouraging her. And when a midwife encourages a woman to walk around, during labor, just respecting women's choices. This is what we mean by care. It's not just telling the woman, okay, you're in labor, I'll see you after 4 hours, you're going to be fine then, and then you walk away. But there's no support. There's no psychological, emotional support. And this is not something that we obstetricians can do, because as a doctor, you're multitasking. You're running an outpatient service. You may be doing an emergency surgery. You may be scanning a woman. You may be running an operation theater list. But a midwife is trained specifically to support women in labor. So when midwives and doctors work together, magic happens. Research has shown that doctors who are most empathetic have the lowest risk of burnout. Spending time with the patients that you're so privileged to serve actually saves time and saves costs. Buddha has said it very well. Our sorrows and wounds are healed only when we touch them with compassion. And unless we care enough, we won't be able to cure. Touch is so important in our field of work. And during the pandemic, this was probably the most difficult aspect of our care. It was very difficult to be in a birthing room with a woman, getting her to wear a mask, getting her to wear a visor, trying not to get too close, and yet it was difficult. I think we broke all rules in delivery rooms because you have to touch. When a woman is in pain, just putting your hand on her shoulder or just holding her hand and saying, you're doing fine, don't give up. And I didn't realize that there are approximately 5 million touch receptors in our skin, 3,000 on our fingertips. And the magic of touch in care, there's enough scientific evidence to show that when touch happens, there's so much that goes on, apart from immunity and oxytocin and pain perception. This is one of my favorite pictures where Princess Di didn't use gloves to shake hands with a man who had AIDS, only to prove that touch is never going to transmit AIDS. Premature infants, and I'm sure that you've heard about kangaroo mother care, I'll show you a picture of that. But we believe that when babies are admitted in the neonatal intensive care unit, we encourage mothers to come in and hold their babies, even if the baby is on oxygen. Put your hands on the baby, talk to your baby, because your baby requires the mother's touch. No amount of compassionate care by a nurse can make up for that touch and that hug that the mother gives her baby. Infants massaged regularly by their parents are far healthier, grow faster, and are emotionally secure. And this is what we mean by kangaroo mother care. This is what we offer to all our premature babies who don't need an intensive care. We get them out of the NICU, the neonatal intensive care unit, get mothers to strap them to their chests, and it's amazing. These babies put on weight at a much faster rate than the mother ends up paying only for her bed and for the food that she's given. So costs come down and mothers are fully involved in the care of their babies. And this is one of the most important aspects of touch. Finally, I'd like to end by saying that now more and more science is showing that compassion forms a major part of healthcare. So while we struggle with rising costs, while we look at technology and more machines coming into our rooms, we need to never forget that the foundation of care rests on compassion. This is a link that you can probably go to just to listen to a very interesting talk on touch. But I'd like to end this now with on a very positive note, while we talk about the need for respect, dignity, privacy, compassion, this is what is happening today in Telangana state, in 16 facilities of the state across 12 districts of Telangana, thanks to the government wanting midwifery care in public hospitals. So this video will give you a glimpse of what's happening in our hospitals, public hospitals. This is in Sangareddy. That's a midwife handing a baby over to parents. The joy on that mother's face. And this is the first pilot group we trained in 2017. They are involved in antenatal care, childbirth classes, showing them different positions, how to use birthing balls, bringing order into the antenatal OP. The head nurse says that things changed. Introduced birth companions.
నా పేరు డి రూతమ్మ. ఉత్తరపల్లికి వచ్చాను. ముందు ఆపరేషన్ అయ్యిందన్నమాట. నాకు రెండో కాన్పు ఇది. లేబర్ రూమ్లోకి వెళ్ళిన తర్వాత కేసరీలకు మిడ్వైఫ్ గారు నన్ను రిసీవ్ చేసుకున్నారు. పెయిన్స్ బాగా వచ్చిన తర్వాత ఎక్సర్సైజ్ చాలా చేయించింది. స్ట్రెస్ చాలా తగ్గింది, పెయిన్ తగ్గింది చాలా. డెలివరీ టైం బాగానే ఉన్నా కానీ తొందరగా డెలివరీ చేయించింది మేడం. ఒక కుట్టు కూడా పడకుండా నాకు మంచి నార్మల్ డెలివరీ చేసింది మేడం. మేడంకు థ్యాంక్స్. చాలా హ్యాపీగా ఉన్నాను.
బేబీ అస్సలు ఇట్లా కిందికి జారలేదన్నట్టు, దానికైతే ఎక్సర్సైజ్ గుడ్, మంచి సలహా. స్టెప్స్ ఎక్కుమనేది, బాగా వాకింగ్ చేయమనేది. అసలు ఎక్స్పెక్ట్ చేయలే నార్మల్ అవుతుందని చెప్పి.
See the joy on her face.
చూయించుకోవడానికి వచ్చినట్టు అప్పుడే పెయిన్స్ వచ్చినాయి. పెయిన్స్ వచ్చేసరికి మేడం దగ్గర తీసుకెళ్ళి సుజాత మేడం దగ్గర. సుజాత మేడం మంచిగా చేసింది, వాకింగ్ చేయించింది, మంచిగా డెలివరీ చేసింది. గోడకు నించోపెట్టిరు, నాకు ఇష్టం ఉన్నట్టే సైడ్ మీద వండబెట్టిరు, దబ్బుని డెలివరీ చేసి పుట్టంగానే బాబున్న మీద వేసి పాలెక్కిచ్చారు.
पोस्ट डेट हो गया था मेरा, तो सर्जरी को लेके जा रहे थे. मिडवाइफ आए, मत जाओ सर्जरी को बोल के. बाल एक्सरसाइज, ब्रीथिंग एक्सरसाइज, स्ट्रेचिंग एक्सरसाइज, मेरे को पेन रिलैक्स हुआ, मेरी नॉर्मल डिलीवरी करे. हैप्पी हो गई मैं.
Yeah. I felt we had to end on a positive note because care is so important. Respect, kindness, dignity is the right of every woman. And whether she's poor, whether she's rich, black, white, but the moment of birth is the most significant moment in her life. And at that, if we can make it a positive experience, then the next generation of babies, the next generation of mothers start on a good note, and the next generation of birthing the new humanity is probably the most wonderful experience that we can offer women. Thank you.
That's an amazing presentation, ma'am. I can't thank you enough.
Thank you.
For the members who are present, I'll try to capture that in a very small way. And that is, here is a leader, ladies and gentlemen, who has made a presentation on the birthing issue and the birthing related problems. Most of these problems we have inherited because of a cultural issue, because of ingrained biases, because of lack of scientific knowledge, variety of reasons there could be. But then most of us were blindly following certain methodologies and processes which were not actually healthy. And therefore, the concept of care and cure, as sufficiently been explained by Dr. Evita, is an example of innovation when she has proposed midwifery. Midwifery is something which I've heard for the first time, but in the olden days, there used to be some kind of midwifery, and my grandmother used to talk about it. And elderly women who had definite experience and exposure to the birthing process, they used to come together and help the birthing women in this process. I think the innovation that we are talking about here is identification of a problem and proposing a solution. And there's a lot of scientific backing for that. There is a case study or several case studies taken, research conducted, statistics provided in evidence to champion the midwifery. And it has been rolled out with government hospitals. And that is what we have to learn from this entire conversation, ladies and gentlemen. And like all the 53 conversations earlier, this is also a fantastic case of learning from the leaders where innovation has taken place in their own domain. And Dr. Evita, you are the first medical doctor on our platform.
Thank you very much.
And
thank you for the privilege.
we believe that we can learn from any practice, any domain. We had people from social work, people from pharma, people from sports, people from technology, people from space science, and so on and so forth. And today, medical doctor, and more importantly, Dr. Evita, who is here in front of us. Thank you very much, ma'am. We have participants joined from UK and US, apart from various other cities and towns in this country. This is currently being live streamed on Facebook as well. And without taking much time, I would now request Professor Prasad to start the Q&A session. And these questions that we have landscaped are collected at the time of registration by the participants. They key in a question. So we landscape it properly, cluster it, and then we take cluster after cluster with you. In the next 30 minutes or so, we would request you to respond to these queries and enlighten us, ma'am. Over to you, Professor Prasad.
Thank you, Professor Rao. And ma'am, it's been an amazing presentation.
Thank you.
I think the word care you have embodied when you have given the presentation, not just in the manner in which you gave it, but also what you have explained. And as far as I can see it, it's not just the material, you've also delved upon the emotional and perhaps also the spirit in terms of how you've done it. And I think these three put together is differentiates care and puts the attention on care far more than anything else does. Not that a cure is of course vital, and there will always be circumstances where you need to get to cure. But I think you have explained care in the context of cure. Maybe it's not versus, but in the context of cure, I think you have explained it pretty well for the expertise that you have. So thank you, ma'am, for that.
Thank you.
So the first in this set of questions, while going through your website, there is one testimonial which talks about 3 generations of children who have been born at your hospital. So what are the key factors which have helped you to go through this progress? That implies that it has been there for some time and you're carrying the spirit of it ahead. So what are the key factors which have helped in the progress of the foundation and the hospitals over this period of time?
Thank you. Thank you for the question. I believe the way we've grown rests on non-negotiable values that never changed in these 73 years. The first is the fact that we're here to serve, and serve with all honesty, using evidence-based practices. So if you don't keep up with what's happening, looking at the way science is progressing, and reviewing your own practices, auditing what you're doing. So in other words, being honest and transparent, I think these were important values for us. Second, I think service before money is most important. Third, doing the right for the patient. Now, we could have continued with our archaic practices. We could have continued with a high C-section rate, but that's not the right thing. We know today that working with midwives certainly is a better, well, I would say it's optimum care, best care given to mothers. So it meant we obstetricians had to step out of the arena, open our doors and hearts to bring in this whole new cadre, support them. So that meant your revenue may go down because you're not doing so many sections. You've reduced your interventions. You've made birth a more physiological process, which is what it should have been before we doctors medicalized it. So it meant being honest with ourselves. And I think that is the key to what we do. Reviewing, auditing, and admitting that, hey, this is not right. We need to do what is the right thing. And I believe that has helped sustain that trust of generations.
Thank you, ma'am. I think you have again emphasized on the care aspect and what goes into care as compared to cure. And I think a lot of this debate of care, cure, it comes in because of some of the aspects that you have mentioned, and many places because of the lack of it. I think you have highlighted the centric values that you are following, and I think you put values right in the front. And you mentioned about being very logical, looking at scientific evidence, collecting data, looking at it, seeing what you need to change based on that. Then you've also mentioned that your purpose is very important. So therefore, obviously, service comes before money. Money will come automatically, but service comes before money. And the third point is about being honest. And I think here there's a huge example that you've put about how you managed it by the midwifery value chain that you have created over a period of time, and wherein you had to step back because the purpose needed it. The purpose demanded that you do it that way. And I think that illustrates the care aspect of this entire process, not only for perhaps mothers and children, but I think for the entire healthcare management system. It's a beautiful illustration of what care is. Thank you, ma'am.
Thank you, Prof. And also keep in mind, this is reducing costs for mothers, because the very fact that you don't intervene unnecessarily. Midwifery care believes that pregnancy is a normal process in a woman's life. So you don't need to interfere, you don't need to hurry, you don't need to induce, and therefore your normal births increase, which means the woman's need to stay in hospital comes down. Your C-section rate comes down. So the woman's need for expenditure comes down. And this is extremely important for us who are privileged to run our own hospitals. We are answerable only to ourselves. And that's a huge privilege because you can set the tone, you can decide the kind of care that you want to give. And I think that's an amazing opportunity for us.
Absolutely. I think you've added a very important dimension to the care, and that care actually costs lesser. And if you imagine it and structure it pretty well, it actually costs less. I think this is an extremely important dimension. This also leads us to our next question about care and cure being a continuum, where at some point in time it may need cure, but then you have looked at the way you have designed it, you're trying to maximize the care and come to cure only as an exception, which is the entire philosophy of this continuum. So here the question is, ma'am, you have explained for what happens in your hospitals, and you've also highlighted the midwife role in that. I just want to also understand from the technology side of it, as well as the pharmaceutical side of it, because all these are also elements, the equipment side of it, all elements which combine to form the healthcare management. Maybe they are not directly at the center, the patient and the doctor are the center, and then these are constructed around that. Now, how do you see these elements also improving the care and reducing the costs if they're managed well? Can you throw some light on that?
Yeah. Thank you. Thank you. That's a great question, because one of the things that really worries me is our dependence on machines. Technology has changed the way we practice today, and there are amazing advantages. I mean, just take pregnancy itself, with ultrasound being available. You're able to pick up problems with the baby, should there be a problem with the baby. You're able to even attempt certain surgical procedures that would make an impact in the life of that baby. So there are great advantages, but there are also machines that check the heart rate of the baby while the mother is in labor. And unfortunately today, those machines have permeated into all our delivery rooms. Now we know there's enough evidence to show that a low risk, uncomplicated, healthy mother does not need this machine to monitor her baby. All she needs is what we call a Doppler, where you put this little gadget on her tummy, you can hear the loop-doop, loop-doop, loop-doop. And that's very reassuring for the midwife, as well as for the mother herself. But the minute you bring in this machine, it's like taking an ECG of the baby, then your focus is on that machine. It breaks my heart when I see young doctors come into the room, ignore the mother, ignore the birth companion, and just look straight at that piece of paper with the tracing. To me, that is utter disrespect. It's, you're just being swayed. You're looking at a machine. Come in, look at the woman, talk to her first, examine her, put your hand on her abdomen, and then look at the tracing. I feel we need to find that balance between technology and care. On the other hand, thanks to the pandemic, there were some good things that came out. We were able to reduce unnecessary visits and travel for women. You actually consult them, you take a great history, you get them to do some of their investigations, or you plan their visit and make sure that everything is done on that one visit so they don't have to come back and forth. The lab reports can be uploaded. So there are great things using technology, but I feel we must guard ourselves about losing out on the humane aspect of care.
Absolutely, ma'am. I think in some of your slides, you also focused on this by talking about the patient being at the center of this entire discussion of care, and that everything else is there outside that. And I think the leaders in this healthcare management being doctors, if doctors get more cognizant of this, and that is the kind of culture which comes in, I think this aspect will get taken care of. Thanks a lot, ma'am. I move to the third question. The information from the Registrar General of India about MMR, maternal mortality ratio, is that it is about 103 in 103 from 2017-2018. There is a slight dip, but still, as you mentioned, it is in single digits in the two countries, UK and Sweden. You did mention that. Now, I suppose there is a journey which is traveled here. I mean, India being what it is and what it was a few decades back. If you can enlighten us on the key issues which are there, which are involved in reducing this figure, the criticalities in reducing this figure from what it was till what it is now, and the journey to the single digit. Could you help us to understand that?
Sure. If we can look at the most common reasons for mothers dying in our country, then we can start looking at solutions. The most common reason today is postpartum bleeding, and which means 26 million mothers are birthing across our country. So if every mother has a skilled birth attendant with her who knows how to handle obstetric emergencies, and postpartum hemorrhage is one of the most basic emergencies that a midwife is trained to handle, then that straight away reduces the maternal mortality figures. I mean, I'm just giving you one example. The other is how many women access good antenatal care during their pregnancy, where you can pick up mothers who are potentially going to develop complications that may be life-threatening. And this is what a midwife is trained to do. So having the right mix of professionals caring for these women and working in collaboration with a good referral system, then that woman who's got a potential problem can be referred to a higher center and not land up in a small hospital when help is not available. The third is the very poor referral system that we do have. We've heard of enough tragic stories during the pandemic where women were sent from one hospital to another. And that's another reason why we are losing mothers, because of not being able to access care. But research in the last few years has actually shown us, Professor Prasad, women are beginning to reach the center, but they're not getting the right care. In other words, we do not have enough skilled professionals in our institutes. And that is why globally, the world is screaming for midwives. Midwives have to be the backbone of our maternal and newborn health services, because when they become that backbone, they can risk categorize women, they can take care of the healthy women, then the ones who are complicated are referred in time, looked at better, and outcomes will improve.
Excellent, ma'am. I think you have highlighted the root cause, and perhaps a lot of work that your foundation is doing is directed towards this, from what I can gather from the website as well as from the presentation that you have made. The midwife being a very, very important part of this chain of service that happens to a woman.
Yes.
And I think a lot of work that you're doing currently is also oriented towards that.
Yes.
Yeah. So I think it also therefore gives us a very good example of what a lot of hospitals, doctors can contribute in this particular area in terms of looking at this particular root cause. Thank you, ma'am.
Yeah, thank you. But the sad fact is we don't have private hospitals investing in midwives. We've been promoting midwifery for the last 11 years, but there isn't a single private hospital today that has invested in midwifery. And the reason I suspect are many, but I think one of the main fears is the obstetric fraternity needs to understand, needs to accept that midwives are colleagues. They are not assistants, they are colleagues, and we need to work with that mutual respect and trust. And that is the main barrier that's preventing us from moving forward. And that's why I'm particularly delighted that the government of Telangana has taken midwifery, and embraced it, and is determined to have every public hospital filled with midwives. And I believe the whole landscape will change. My heart bursts with joy to know that the poorest of the poor woman in a district hospital where midwives exist is getting the same care that we are giving women at Fernandez Hospital. To me, that's what equitable healthcare is all about.
Absolutely, ma'am. I think you have highlighted another aspect here, and that's what makes this hospital chain and the foundation remarkable. And when we did talk about care, and when we go through the kind of activities that you do, I think this stands out. It is remarkable, not just remarkable, it is exceptional. Because as you mentioned, this is not normally done by other hospitals, and you have taken it as part of your purpose in order to do that. So we move to the next question, ma'am, and this is the next step of this. So if you need to envision this, put a vision for rural India, where hospitals like this don't exist, and perhaps the reach of hospitals, except for the state, perhaps which can do something about it, is not as much as it should be. Statistics keep saying that. What kind of vision do you think will drive the system to put the woman at the center and also ensures that she gets the relevant services which are required. What is your vision for this?
If I had a magic wand, I would invest in smaller hospitals out in the community. Probably 30-bed hospitals would be the max, offering what we call level 2 care with a very strong midwifery task force and a very small group of doctors, because where there are midwives, you're risk categorizing these women and your need for cesareans would be less than 10%. And the true complicated mother will then go to a tertiary hospital where she would require that kind of care. But if majority of the women don't need to travel far, but if we have what I would call community hospitals, and this to me is the way forward. Women should not be spending lakhs and lakhs of money to birth. Those who want that kind of care, that's fine. I have nothing against it. We have a hospital providing that kind of care. But I do believe that we have a responsibility to care for women across the socioeconomic spectrum. And I am a firm believer of collaborating. To me, we who are privileged to run our own establishments, we need to work with the government and see how we can help. Because 26 million births is a lot of, it's a huge volume. How can we work with the government in helping reduce the stress and improve care is really by public-private partnerships. We also look forward to working with NGOs in rural India by strengthening, their midwifery force in terms of training. So going forward, to me, it has to involve generosity on the part of private practitioners, changing our childbirth practices, bringing in midwives into our hospitals as mandatory, being mandated as important task force. And only then can the landscape change.
This is very insightful, ma'am. I think, from what you've responded to in the earlier questions, I think there is, you have focused on the disaggregation of the skill set from what is conventionally looked at. And you also talked about empowering the skill set, which does a lot of value across the service chain. And therefore, you're also giving a suggestion of how to increase that skill set, particularly in the kind of rural areas that we are talking about. And you have suggested the community hospital as being a nodal point where this can get served. Thank you very much, ma'am. We come to the end of this cluster. I hand it back to Professor Rao.
Thank you, Professor.
Thank you very much, ma'am. I think it's been a wonderful conversation that is evolving. And while we are thinking that we just started talking about it, we have almost reached the end of the session time that I have actually borrowed from you. However, I will pursue with my questions, ma'am, and I request you to answer these questions because there are many more questions. I'll reduce it to very, very few and most important ones, because in your responses to earlier questions, you had already taken care of most of the other questions to come by. I see very interestingly, a lot of doctors also have joined. I welcome Dr. Harita from Nellore. We have one doctor from Bangalore. We have Subhash from UK. We have Lakshman from US, and some of them I don't know. So welcome all of you. Thank you very much. In case you have any question to ask ma'am directly, please get ready. We'll open the mics for you. But let me finish my quota first. Ma'am, short questions like we all have experienced what happened during the COVID. Probably there was a gap in terms of care because of the restrictions of COVID over the last 2 years. But post-COVID, what are the new approaches and preparedness that, especially at your hospital, that you're planning to evolve?
Yeah, thank you. There were a lot of lessons learned during the COVID. during the pandemic. And one of the things that we're very conscious about is to keep the costs as low as possible. Because post-pandemic, people have been hit economically, financially, and we really need to be very, very conscious of that. So how can we optimize care in terms of reducing visits, travel? How can we use technology to the maximum? The other thing that we're looking at is how can we network or continue the network with doctors in the districts so that they are empowered to take care of women, and women don't need to come to Fernandez to birth. So collaboration with colleagues, we feel is a very, very important aspect of reducing costs and yet not compromising on quality, using technology to the maximum. In designing hospitals as we go forward, we're looking to see, how do we prepare ourselves if this should happen again tomorrow? We are working with people, but I don't have a blueprint of it at the moment, certainly not. But it is something that we need to consider.
Great, ma'am. Your use of technology, collaboration with fellow doctors in various districts, so that we cut on the time to travel and the cost to travel, and overall the cost of healthcare reduces. That's a very nice way of approaching healthcare itself, not just specific to what you're doing in terms of birthing care and other aspects of Fernandez hospitals. That's a larger ambition and a lesson for many others who are medical entrepreneurs in this country, so to say. The other one question I would like to request you to respond to, ma'am, is Fernandez Hospital has been there for many years, and you have been there at the forefront of this activity, bringing innovations, educating people, making sweeping changes, sometimes large-scale changes with the value proposition like midwifery and all. How do you manage your hospital being the managing director or being at the helm of the affairs? Or in our language, what are your KPIs? What are your key performance indicators with which you look at and say that your hospital is doing well?
That's a tough one. Okay. The most obvious, I guess, would be the numbers that we deal with, so that there's an element of trust if women continue to come to us. The fact that we see about, we have an annual birth rate that's close to 10,000 a year, to me is an endorsement of trust. That could be an indicator, but that's not the only indicator. I would also look at, how many days does the woman stay in the hospital? Are we giving I don't like to use the word patient because most of our women are pregnant women, but let's use the word patient for now. Are we giving every patient optimum care and cost-effective care? To me, those indicators are very important. What is the number of adverse events or medical errors, that we have? So there's a very strong audit on that. The other thing that I would be very concerned about is the culture. Is every touch point where a woman meets an employee of Fernandez, is that person representing the philosophy of care and compassion? To me, that would be an indicator of success. And I worry about these aspects. I hope I'm making some sense.
Amazing, ma'am. I think of all the indicators that you mentioned, it can never be exhaustive, obviously, but one of the important things is to measure the culture part of it. Maybe a lot of things are in your hand when you are selecting the doctors, the kind of people who are working for you in the hospital. You would probably have an opportunity to evaluate the compassion quotient to some extent. But in practice, when they actually display compassion, how do you measure that? Because you're not there all the time with each and every doctor or the associate in your hospital. But what is one indicator that tells you that the culture is on track?
Yeah. I think one is to meet the staff time to time and just ask them, which I've been doing over the last few years, every week, especially before COVID. I would pull 4 names out of a hat and meet them. And the employees were told just half an hour before they could meet me, and just have a chat with them and first find out, about them. How do they feel? What makes them work in Fernandez? How do they respond? Just getting to know them. So you get a feel of, has this person actually got the culture? And does he or she know what Fernandez is all about? That's one. Second, the feedback. People who really care about Fernandez will make the effort to actually give you feedback. There are people who may exaggerate, who may distort things. That's a different breed, and you will get them everywhere. But I make it a point to read the negative feedbacks and to see. That gives you an idea of, is the culture there or not? And it just takes one individual to destroy everything else that you would have built. To me, one of the worst statements that an employee can make, and that's where I feel we have failed then to get that culture into the person, to say management decision. That is a terrible answer, because if there is a problem, our job first is to find out, how can I help you? And if we have failed to empower that employee and the employee finds relief in saying management decision, then somewhere that culture has not permeated through. And that's a failure. And that's something I look into.
Wonderful, ma'am. It's a big lesson for everyone in every domain that they are operating in. Focus on negative feedback so that you understand where it's actually going wrong. And an instance that you have quoted in terms of one of your associates citing that it is a management decision. It happens in various other industries and sectors as well. It is an indication of probably ownership factor on the lower side. And probably, yes, it is an outcome of culture or lack of it in the organization. So amazing, extremely sensitive, apart from providing the mainstay of care and cure in your hospital. I think these are the lessons for the young managers and leaders who are around the screen today for this webinar. Thank you very much, ma'am. One question I have, this is on the ethics side. Often I have also wondered with various other hospitals, but I don't know how it happens in your hospital, ma'am. For example, there is a mother-to-be who's visiting your hospital, ultrasound scan takes place, and at a certain stage, I'm sure you'll be able to know whether it is a female child or a male child, but we are not supposed to disclose by law. What is the firewalling mechanism that you have in your processes in your hospital, which makes that it is a zero defect kind of adherence?
Thank you. Thank you for asking that, Mr. Sudhakar. Way back in 1985, we had introduced ultrasound, and somewhere around 86, maybe, we were just 5 consultants at that time. We sat down and asked ourselves, are we going to reveal the gender of the baby to our mothers? And we all came to the conclusion that we will not do it as a policy, as an organization. And the reason we did that was because we felt the minute you reveal the gender, there would be an element of disappointment because you never know what the parents really want. So if it happens to be a boy, they'd be disappointed. And there are enough studies to show that emotions are transferred to the baby in utero. Because when you go and actually look into the evidence, a baby that's welcomed is emotionally secure. And I say this from my own experience. I'm number 3 in the family. My sister, my brother, me, and my younger sister. And so often my mother told me through my life, and even a few weeks before she died, she would say, Evie, your father and I longed for you. You arrived 3 years after your brother. Now, a statement like that from a mother to a child saying, I longed for you. There were no words like, you were a daughter we wanted, or you were a son. Just, we longed for you. And that is it's the best gift you can give. And if a mother experiences any kind of negative emotions towards the baby she's carrying, that gets transferred to that kid. And the kid is going to feel that rejection in some form or the other. So way back in 86, as an organization, we took that decision never to reveal the gender. So when it became law, it really wasn't, it didn't make any difference to us.
Wonderful, ma'am. So it's an organizational policy which was later supported by law. And by then it has already been part of your culture. Yeah. So wonderful. And I think while explaining this particular factor with an example of your own, you come across, and if I'm not exaggerating, you are epitomizing that compassion and care so well. If anybody listens to you, ma'am, they'll rush to your hospital.
Oh gosh, you're embarrassing me, please.
Well, I will quickly take one question. We have Dr. Harita. She's a medical oncologist and she has a question about pediatricians. Can I request Dr. Harita to ask question herself? I think that's better, a doctor talking to another doctor. We'll open the mic, Srikanth, for Dr. Harita. Yeah, she's there.
I'm reading her question. Do you want me to answer?
Yeah, she's almost there on the mic, so we can. Sure. Dr. Harita, you can start. Unmute yourself, please.
Probably not able to unmute. Maybe you need to unmute her?
Yes, we have done that.
Well, I could start answering.
Yes, yes. Please go ahead.
The question is, do you think we need a pediatrician to attend every delivery, which is the practice today? No, certainly not, Harita. We thought that was important in the early years, but today with midwifery, every midwife is trained to resuscitate a newborn. And so we do not expect a pediatrician at every birth, certainly not. But if there are signs, telltale signs that indicate that there may be a problem with the baby, then it's good practice to get the pediatrician to stand by should there be a need. Babies are put in NICU for observation. Yes, Harita, this used to happen even in Fernandez, but today all pediatricians, neonatologists support the belief that mother and baby should not be separated. In fact, after the cesarean, the mother and the baby are in the post-operative ward, and we've invested in these, I know there's a scientific name to it, that keeps the baby warm, because while the ACs are on for the ICU, for the post-operative ward, baby should not get hypothermic. But I'm absolutely convinced mother and baby should never be separated. That's why skin to skin after birth, even in cesareans, we give the mother the privilege of, her right to skin to skin. Do you believe in kangaroo care? Of course we do. We introduced it in 2004, Harita. We have a ward in all 3 hospitals for kangaroo care. It's reduced costs for our couples tremendously, and it's scientific. And I think that's a wonderful scientific way of handling unnecessary stay of babies in NICU. I'm all for it, yeah.
Wonderful. Thank you very much, ma'am. That has sufficiently answered the question. In case others do not have any questions, what I'll do quickly is I request Professor Prasad to take one question and probably give it back for me to wrap it up and then close the show.
Thank you. Ma'am, you have, we offer a healthcare management program in our flexible learning programs. And I must say that after the finance specialization, the most popular specializations was hospital administration and healthcare management.
Oh.
This is in our flexible learning program. But what I find and we have a course called patient experience management.
Mm-hmm.
And the way you have explained whether it was the KPIs or whether it was a customer touch point, not customer, patient touch point, and it was about empowerment, about experience, and the need for certain kind of soft skills. I think there was a question in the chat box about soft skills. All this was very visible when it came to patient experience management.
Mm-hmm.
So one of the audience questions was, do you think doctors need to go to some level of understanding about management as also some degree of soft skills? You have displayed that perhaps without a qualification in that, but do you think as a profession, it needs something like that?
Yeah, thank you. That's a great question. I'm absolutely convinced we doctors need to be trained in certain skills. One is communication. Documentation, of course, is part of our training, but communication. And also understanding sometimes the economics of healthcare. I think it would help because we need to be more and more conscious of making healthcare as cost-effective as possible. And if we can understand that, I think we'd be better at our jobs. But let me share something with the audience. Leadership was thrust upon me in 1985, when my only brother died rather suddenly of a medical condition. My parents were quite shattered, so I had to take over the hospital. And in the initial years of my leadership, I was horrible. I was abrasive. I was intolerant. I wanted things done today. I would shout. I would throw instruments in the theater if they didn't work. I mean, if I look back at those early years, I feel ashamed. And that was very poor leadership. And I began to read about leadership, management, how do you handle people? And my colleagues who were with me because I was building a team were amazing. They had the courage. They would come and sit with me at the end of the day and they'd say, Evita, your behavior was terrible. Why did you shout at that poor nurse? Why did you destroy her confidence? You could have said it differently. And I began to reflect on my behavior. And one management book I read said only cowards shout at their employees because employees can't shout back. And that I kind of carved on my heart and in my brain. And I began to work on my, what I would call weakness. And I had to discover, I realized that you have to lead by example. And only then can things start percolating down. It's up to me to set the tone. And that is probably one of the hardest parts of a leader, to set the tone and to lead by example. I think that's an extremely important lesson for all of us, because as doctors, we are leaders, whether we like it or not. We have a circle of influence. We are public figures. People look at us. You don't have to be sitting at the managing director's seat to be a leader. You are leading just by being a doctor, because people come to you with trust. And therefore, I need to have values that are non-negotiable. I need to be taught certain things. If I've not been told that I have to greet a patient, introduce yourself, I wouldn't be doing it. And to me, that's utter disrespect. And I was horrified when I was told yesterday that some of my doctors are entering the outpatient clinic and they don't introduce themselves. I thought, good God, to me, that's somewhere we failed. Our culture has been eroded. So we need to be taught these skills, Prof. I'm afraid we have to have these lessons.
I think you have hit the nail on the head. You have ended with manners, which is about introducing oneself, which we actually learn in school. Mm-hmm. And then you have centered around leadership, which is what the whole story is all about. And I think you also touched upon certain tools, certain management tools which are required in order to manage. But I think the center of what you have highlighted is leadership. And that when you have to change, and you have your hospital as well as your foundation has done to reach the focus of care that you're giving today from perhaps what you were doing in the 80s, because you felt that is the right thing to do. And if you want to handle change, certainly leadership is the core of it. And I think you've highlighted the right point in this, ma'am. Thank you very much. I give it back to Professor.
Thank you very much, ma'am. We feel like continuing this conversation, but we will have to respect the time and respect your time, especially. What I will now do is I will attempt as a brief summary for the benefit of our participants and then close the conversation with your permission, ma'am. There are several lessons between education and healthcare. Both these sectors and domains have their customers, so to say, patients or students, as may be the case. They stay with you while you are providing the care, while you are actually teaching them, while they're experiencing your product, they're still with you. That is education as well as healthcare. And therefore, not only the process, but they're also life-changing. Mm-hmm. Education is a big investment. Similarly, healthcare is a big investment. The experiences that they gain will change their life, as we have also heard from you in many cases, many examples, and especially with birthing care and the processes involved with that, and the care part of it, especially epitomized by your organization and yourself in a manner that has been game-changing, not just in the field of, it would be now knowing more about it, unfair to say game changer in obstetrics. I would say game changer in birthing process itself. The important lessons that we have learned, ma'am, one of them is to understand that touch is a very important determinant in terms of healing, in terms of caring or curing as well. In various processes of intervention, touch scientifically has got this advantage of transferring that trust and faith, and therefore the healing process as well. And that has been very nicely ingrained into the value proposition that you have put forth in terms of midwifery. Midwifery is not just a value proposition, it's also a solution to the ongoing problem. And you have pitched very rightly with the government, with other private hospitals and the budding doctors around about midwifery. And these processes will definitely ease a lot of stress and pain. And on the other hand, they enhance the birthing process, associated memories with the birthing. And I'm sure women will be very, very happy to become mothers when they go through such processes. And that's an amazing transformation, amazing solution, and an innovation that you have put forth. Thank you very much, ma'am. We have Dr. Mamta Achanta is one of the participants. She's like my sister. She's heading an NGO called Taruni. She's on the screen. She's there in the list. You have mentioned the role to be played by NGOs, especially apart from government, apart from other private hospitals, apart from colleagues. NGOs have a very important role to play in terms of skilling, encouraging people for midwifery, and then together collectively easing this process or reducing the stress and also reducing the cost. The other learning for us, ma'am, is about when you look at a practice, is it only heavily loaded with compassion, heavily loaded with a feel-good factor, or does it make business sense? this is a fantastic example of today's discussion where I would say it makes business sense to be compassionate.
Absolutely.
Like in organizations other than medical care, we generally talk about practicing diversity and inclusiveness. Diversity and inclusiveness is not just a politically correct statement or a feel-good factor to score some brownie points. It actually makes business sense. And if it makes business sense and if it is part of your organizational culture, then we'll be doing a greater service and greater good for the society, for every mother in the case that we are discussing here. And so any amount of time and energy and money to be invested in building this compassion and a whole cadre of midwives who can take care and help this process is a very important outcome that has emerged in the entire discussion, ma'am. Thank you very much.
Thank you.
And the last point is your contribution out of 26 million births that take place every year and 10,000 births that happen in your hospitals is an amazing, and that is one of the measures, but there are many intangibles that you are epitomizing. That's a different point. I would like to share with you that about 20 years back, I walked into your hospital, roughly 20 years back, 2001 May. And you looked at my wife and you asked about me. And of course, one hand you put on her abdomen and the other one was touching her fingernails. And you asked her, where did you buy this nail paint? That is fresh in my mind as much. I was just observing from a distance of 1 meter. And then you asked me many questions. And then you said, please join for every follow-up, every checkup. And also somewhere midway, you told me that I should be showing up in the labor room as well. And I did that. And I did that. Both my daughters were birthed at Fernandez Hospital's Bogulapunta. And it was an amazing experience. And I'll tell you, my mother and my aunt were in the room that we had booked inside the hospital. And we went into the labor room because of a requirement. So my mother was waiting that I would call her to assist. But I walked back into the room with the baby. That is the biggest disappointment for my mother and the greatest satisfaction as a father.
I'm so glad that your wife had a good birthing experience, really.
She had 2 good experiences of birthing in your hospital, ma'am. And after that, I had no opportunity of going back to your hospital.
Well, thank you, Mr. Sudhakar. I didn't realize that we had this connection, honestly.
Amazing connect with everyone in this city that I have known, ma'am. They tell you lots of stories. And there was one friend who mentioned about 3 generations of their family members have gone through this wonderful experience in your hospital. And many doctors, many colleagues, many friends, people working in corporates, everyone who have listened to you all at different times. You are an angel, and I'm not exaggerating. And I have all those texts with me. I have taken all those texts and I'll share with you later, ma'am. But it is something that Dr. Evita, also known as Angel. So that is something which is very, very important.
I'm not sure my colleagues would call me that.
but ma'am, I'll tell you, I know some of my friends who are your colleagues who are working in your hospital. So doctors who are working in your hospital for quite some time, they've been working for quite some time. Gynecologists, that's what we call. We have now learned many terms. With that, ma'am, I would like to thank you from the bottom of my heart. On behalf of our vice chancellors who have joined this conversation, several leaders from our tech school, leaders from our universities in Jaipur and other places. We have 11 universities, so most of them joined from, the leadership team joins from all these locations, and all the friends from UK and US and other doctors who have responded and joined. I would like, on behalf of them also, I would like to thank you, ma'am, for this time. 90 minutes of your valuable time we have taken and learned. We shall remember this for our lifetime, ma'am. Thank you so much.
Thank you. Thank you,
Thank
Mr.
you,
Sudhakar. You've been very generous, but I've enjoyed the privilege. Thank you very much. Yeah.
Thank you, ma'am.
Bye.
So, ladies and gentlemen,
Yeah.
thanks for joining, and you have enjoyed the leadership conversation with Dr. Evita Fernandez. Do come back for next week's conversation. That is next Friday at 7:30 p.m. We will let you know the details and contact you. Till then, do take care and read more about Dr. Fernandez and also the Fernandez Foundation and hospitals. I know that Fernandez Hospital is in Bogolpunta, it's in Hyderabad, it's in Banjara Hills, Stockholm, yeah, and I don't know where all.
No, that's it. That's it.
Thank you, ma'am.
Thank you.
All
Thank you.